Acute bronchitis is defined as a lower respiratory tract infection which causes inflammation in the bronchial airways. It is a clinical diagnosis characterized by cough resulting from acute inflammation of the trachea and large airways, but with no evidence of pneumonia. Pneumonia is an infection of the lung tissue in which the air sacs in the lungs become filled with microorganisms, fluid and inflammatory cells, affecting the function of the lung. Community-acquired pneumonia is acquired outside of hospital. Severity of illness classification CRB-65. The CRB-65 score for mortality risk. The score is calculated by giving 1 point for each of the following prognostic features: confusion, new disorientation in person, place, or time, or abbreviated mental test score 8 or less; raised respiratory rate, 30 breaths per minute or more; low blood pressure, diastolic 60 mmHg or less, or systolic less than 90 mmHg; age 65 years or more. A score of 0 corresponds to a low risk of death, less than 1% mortality risk. A score of 1 or 2 to intermediate risk, 1 to 10% mortality risk. And a score of 3 or 4 to high risk, more than 10% mortality risk. Use the CRB-65 score to help decide whether an adult with suspected community-acquired pneumonia requires hospital admission. Score of 3 or more, arrange urgent admission to hospital. Score of 1 or 2, hospital assessment should be considered, particularly for people with a score of 2. Score of 0, treatment at home should be considered, depending on clinical judgment and the person's social circumstances. Acute bronchitis is usually caused by a viral infection. The most common viruses associated with acute bronchitis include rhinovirus, enterovirus, influenza A and B, parainfluenza, coronavirus, human metapneumovirus, respiratory syncytial virus, and adenovirus. Bacteria are detected in between 1 in 101 in 10 cases, including Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis. Atypical bacteria such as Mycoplasma pneumoniae, Chlamydophila pneumoniae, and Bordetella pertussis rarely cause acute bronchitis. Community-acquired pneumonia is usually caused by bacterial infection. Usually, the causative organism is not identified. The likely microbial causes of community-acquired pneumonia depend on factors such as local epidemiology, severity of disease, and the person's sex, age, and comorbidity. Streptococcus pneumoniae is the main causative pathogen of community-acquired pneumonia worldwide, independent of age. Other causative organisms of community-acquired pneumonia include Haemophilus influenzae, Staphylococcus aureus, group of Streptococci, Moraxella catarrhalis, and atypical bacteria such as Mycoplasma pneumoniae, Chlamydia, and Legionella species. Rarely, pneumonia is caused by pathogens not covered by standard empirical treatment, including Pseudomonas aeruginosa, Enterobacteriaceae, extended spectrum beta-lactamase, and methicillin-resistant Staphylococcus aureus. Viral pathogens can also cause pneumonia, including influenza A and B, respiratory syncytial virus, adenovirus, and some coronaviruses. Complications of acute bronchitis. Acute bronchitis is usually a mild, self-limiting illness. The cough usually lasts about 2 to 3 weeks. Most people recover fully with no residual symptoms after an episode of acute bronchitis. Around a quarter of people will have a cough for more than 4 weeks, and in some, cough will persist for up to 6 months post-bronchitis syndrome. Pneumonia may occur as a complication of acute bronchitis, particularly in older people. Complications of pneumonia. Community-acquired pneumonia has a mortality rate of less than 1% of people who are managed in primary care. Mortality ranges from 5 to 14% in people requiring admission to hospital, and rises to more than 30% in people requiring intensive care. Complications include pleural effusion and empyema, lung abscess, acute respiratory distress syndrome, septic shock, and disseminated infection. Clinical judgment must always be used to diagnose community-acquired pneumonia, because no combination of symptoms or signs is clearly diagnostic. History. Ask about onset and duration of symptoms. The type of cough, dry or productive. Additional symptoms such as breathlessness, wheeze, pleuritic pain, and fever. Smoking status. Cough is the predominant symptom in both acute bronchitis and community-acquired pneumonia. Examination. Examine the person, paying particular attention to the chest. Measure the person's temperature, pulse rate and blood pressure, respiratory rate, and assess for signs of confusion. Be aware that in elderly people with pneumonia, symptoms may be less evident, for example, altered consciousness, gastrointestinal discomfort. Typical symptoms, cough, fever, and difficulty breathing may be absent. If an adult has clinical symptoms and signs suggestive of community-acquired pneumonia, assess the severity of the illness using clinical judgment and CRB-65. In young people, use clinical judgment to assess the severity of symptoms and signs, taking into account features suggesting severe community-acquired pneumonia, including difficulty breathing, oxygen saturation less than 90%, raised heart rate, grunting, very severe chest and drawing, inability to drink, lethargy, reduced level of consciousness. Investigations. Investigate the person with pulse oximetry. Arrange urgent hospital admission for people who require supplemental oxygen. C-reactive protein test. If the person has symptoms of a lower respiratory tract infection and a clinical diagnosis of pneumonia has not been made, and there is uncertainty about whether antibiotics are indicated. A chest X-ray if the person has suspected community-acquired pneumonia, and they are at risk of underlying lung pathology, for example, lung cancer, or the cause is uncertain. Chest X-ray may be normal in acute bronchitis but abnormal in pneumonia. Chest X-ray may be helpful to rule out pneumonia, but is not normally initially necessary for most people with suspected community-acquired pneumonia who are managed in primary CI. Do not routinely recommend microbiological tests for people with low-severity community-acquired pneumonia. Request a sputum culture for a person with moderate severity community-acquired pneumonia for whom community management is appropriate. Acute bronchitis management. Refer to hospital or seek specialist advice on further investigation and management if a person with acute cough has any symptoms or signs suggesting a more serious condition, for example, sepsis, a pulmonary embolism, or lung cancer. Advise the person on self-care strategies such as adequate fluid intake and the use of paracetamol or ibuprofen for symptomatic relief. Some people may wish to try the following self-care treatments: honey, pelargonium, a herbal medicine, over-the-counter cough medicines containing guaifenesin, an expectorant, over-the-counter cough medicines containing cough suppressants, except codeine, if the person does not have a persistent cough or excessive secretion. Advise the person to stop smoking. Advise the person to seek medical help if symptoms worsen rapidly or significantly, do not improve after 3 to 4 weeks, or they become systemically very unwell. Do not routinely offer an antibiotic to treat an acute cough associated with acute bronchitis in people who are not systemically very unwell or at higher risk of complications. Inform the person that acute bronchitis is usually a self-limiting illness, and the cough usually lasts about 3 to 4 weeks. Antibiotics do not make a large difference to the duration of symptoms, only shortening cough duration by about half a day on average. Adverse effects, including diarrhea and nausea, are possible with antibiotic treatment. Unnecessary antibiotic prescriptions may result in antibiotic resistance. Offer an immediate antibiotic prescription if the person is systemically very unwell. Consider an immediate antibiotic prescription or a backup antibiotic prescription for a person at higher risk of complications. For example, a pre-existing comorbid condition such as heart, lung, kidney, liver, or neuromuscular disease, immunosuppression, or cystic fibrosis. Older than 65 years of age with 2 or more of the following, or older than 80 years with 1 or more of the following. Hospital admission in the previous year. Type 1 or type 2 diabetes mellitus. History of congestive heart failure. Current use of oral corticosteroids. If a backup antibiotic prescription is appropriate. Reassure the person that antibiotics are not currently needed. Advise the person to use the delayed prescription if symptoms get worse rapidly or significantly. Advise the person to seek medical advice if symptoms get rapidly or significantly worse despite taking pneumonia management in primary care. Refer adults with community-acquired pneumonia to hospital. Use clinical judgment to determine urgency. Symptoms and signs suggest a more serious illness or condition, for example, cardiorespiratory failure or sepsis, or symptoms are not improving as expected with antibiotics. Consider referring adults with community-acquired pneumonia to hospital, or seek specialist advice if there is bacterial resistance to oral antibiotics, or the person is unable to take oral medication. Use the CRB-65 score to help decide whether an adult with suspected community-acquired pneumonia requires hospital admission. Score of 3 or more. Arrange urgent admission to hospital. Score of 1 or 2. Hospital assessment should be considered, particularly for people with a score of 2. Score of 0. Treatment at home should be considered, depending on clinical judgment and the person's social circumstances. Use clinical judgment in addition to the CRB-65 score to decide if an adult should be admitted. Other factors that should also be considered include the person's wishes, social support available, pre-existing comorbid conditions and general frailty, if the person is pregnant, pulse oximetry. Advise the person on self-care strategies such as rest, adequate fluid intake, and the use of simple analgesia such as paracetamol for symptomatic relief. Over-the-counter cough medicines are not recommended. Offer an antibiotics for people with community-acquired pneumonia. When deciding which antibiotic to prescribe, take into account the severity of the illness, risk of complications, local antimicrobial resistance, recent antibiotic use, and recent microbiological result. If low severity, based on clinical judgment and guided by a CRB-65 score of 0. For adults, first choice oral antibiotic is amoxicillin 500 mg 3 times a day for 5 days. Alternatively, if there is a penicillin allergy or amoxicillin is unsuitable, for example, atypical pathogens are suspected, options are oral doxycycline 200 mg on the first day, then 100 mg once a day for 4 days, total course of 5 days, or oral clarithromycin 500 mg twice a day for 5 days, or oral erythromycin in pregnancy 500 mg 4 times a day for 5 days. If moderate severity, based on clinical judgment and guided by a CRB-65 score of 1 or 2 and microbiological results when available, and it is appropriate for the person to be managed in the community. For adults, prescribe oral amoxicillin 500 mg 3 times a day for 5 days. Higher doses can be used, and atypical pathogens suspected. Oral clarithromycin 500 mg twice a day for 5 days, or oral erythromycin in pregnancy 500 mg 4 times a day for 5 days. Alternatively, in penicillin allergy, oral doxycycline 200 mg on the first day, then 100 mg once a day for 4 days, total course of 5 days. Or oral clarithromycin 500 mg twice a day for 5 days.